you've never joined us before, we run the series on the second Wednesday of each month from 12 to 1 as a 1-hour session. After a short lecture from an expert, we will share expertise from the rest of the team and then open it up for a time of case discussions. We invite you to share any geriatrics cases, even if it's not related to today's lecture. Our interdisciplinary team is willing to teach and share our collective wisdom with you. We only ask that you keep it HIPAA compliant for case discussion. This CME activity is sponsored by the Hawaii Consortium of Continuing Medical Education, a joint venture between the Hawaii Medical Association and JABSOM at University of Hawaii. This program is also approved by the National Association of Social Workers, the Hawaii chapter, for up to 1 social work CE contact hour. As a reminder, you must complete an evaluation form in order to receive CMEs or certificates of attendance. Unfortunately, we are not offering CEs this month due to time constraints for social workers. Evaluations can be found on our website under Evaluations tab by following the link in the chat box. We also ask that you enter the full name and credentials of everyone in attendance in the chat box so we can keep attendance. Okay, as you know, all sponsors of CME are also required to execute a conflict of interest policy, and speakers are expected to disclose to the audience any real or apparent conflicts of interest they may have with direct bearing on the subject matter. Okay, so Dr. Ross has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So I am pleased to have Dr. Webb Ross with us today. He is a board-certified neurologist with experience managing veterans with mild traumatic brain injury. He also has experience designing and implementing numerous projects as a project neurologist for the longitudinal epidemiologic study of the Honolulu Asia Aging Study. And he is the principal investigator of the NIH, Department of Defense, and VA-funded projects examining risk factors for Parkinson's disease and dementia. Additionally, as a collaborating scientist or co-investigator, he has co-authored papers on the association of head injury, migraines, and Parkinson's disease. As a member of the Parkinson's Study Group and as a Honolulu site PI for the NINDS-funded NIH exploratory trials in Parkinson's disease, he has gained expertise leading clinical trials evaluating medications for Parkinson's disease and has served on the steering committee as a steering committee member for 2 of these trials. With us today at our interdisciplinary team, we have Mary Godham, who is from Public Health Nursing, Sarah Tompkison from our social work from Arcadia, who will be joining us very soon, and Chad Kawakami, who is an associate professor of pharmacy here. Okay, and just finally, just the last few logistics before we get started. Just a reminder, we need to stay HIPAA compliant, so do not share protected health information. We can always discuss cases without identifying information. There's a mute button on the left-hand corner. Please make sure it is on mute, otherwise we will hear paper rustling and extraneous noise. And unmute yourself if you want to speak. There's also a chat button, which if you press it will bring up a chat box. And if you haven't already, please type your name and location in that box so we can take attendance. Okay. So without further ado, I'm going to hand it over to Dr. Webb Ross.
Thank you very much. Thank you for that introduction, and thank you for inviting me to this session. This is the first time I've done a session like this, so I think it'll be really interesting, and I hope it goes well. So as you know, I'll be talking about dementia associated with Parkinsonism. Primarily, I'm going to cover Parkinson's disease dementia, as well as dementia with Lewy bodies. And then I'll go over the differential diagnosis of atypical degenerative syndromes associated with dementia and Parkinsonism. And then we'll talk about distinguishing the dementias of Parkinsonism from other degenerative conditions such as Alzheimer's disease and frontotemporal dementia. And then I'll talk about the treatment of Parkinson's disease dementia and dementia with Lewy bodies. You can go to the next slide. So the prevalence of dementia at any given time, that is, if you took 100 people with Parkinson's disease at any given time, the prevalence is about 30 to 40%. But you can actually find impairment in cognitive function, and that's primarily in executive function or prefrontal lobe function, almost at the onset of disease in many patients. And if you follow a group of people with Parkinson's disease recently diagnosed, if you follow them for up to 10 to 15 years, nearly all of them will eventually develop Parkinson's disease dementia. So it's a really important complication of Parkinson's disease. It's sometimes challenging to treat, and it's associated with, obviously, with profound impairment in quality of life and functioning ability. So the Sydney multi-center study was completed several years ago, and this just makes the point that demonstrates the point that I just made. And this study followed incident PD cases without dementia for 20 years, and at the end of 20 years, 83% had dementia. And then so that means that the incidence of dementia in people with Parkinson's disease is 3 to 6 times higher in Parkinson's disease compared to those without Parkinson's disease. And the mortality in Parkinson's disease dementia is about 1.5 times that of Parkinson's disease without dementia. You can go to the next slide, please. So what are some of the risk factors for dementia in any individual with Parkinson's disease? Well, first, just like any dementia, older age is associated with a higher risk. And then individuals with more severe Parkinsonian signs tend to have a higher risk of developing dementia. And then those with the syndrome more associated with postural instability and gait disorder and rigidity, as opposed to tremor predominant. So that those individuals with tremor predominant, they seem to have a lower risk of developing Parkinson's disease dementia than those who have the more rigid akinetic variant of idiopathic Parkinson's disease. And then REM sleep behavior disorder, or rapid eye movement sleep behavior disorder, seems to occur equally in people with Parkinson's disease and Parkinson's disease dementia, with prevalence of REM sleep behavior disorder in about 30 to 40% of individuals. So REM sleep behavior disorder is a condition where the individual, instead of being paralyzed during rapid eye movement sleep when we dream, they're actually acting out their dreams. They have dream enactment behavior, and this can lead to violent behavior while they're sleeping, where they injure themselves and even injure the spouse. So it's something that really you need to ask about when you're evaluating these patients. Okay, next slide. So what are the clinical features of dementia in somebody with Parkinson's disease? So executive function impairment occurs very early and, generally speaking, is severe. And by executive function, I mean those behaviors that are involved with planning and initiation of complex behaviors. And I mean behaviors that are impairing someone's functional ability, like disinhibition and impaired self-monitoring and impaired self-regulation. They have early decrease in verbal fluency without other signs of aphasia. And by verbal fluency, I mean the ability to generate a list of words in any given category. And so at the bedside, one useful test to do is assessing how many animals they can name in 1 minute. Or another nice test that comes from the Montreal Cognitive Assessment is naming as many words that begin with the letter F in 1 minute. And of course, you cannot use proper names, and you cannot use numbers like 41, 42, 43, and so on. So anybody that cannot name at least 12 animals probably has an impairment in verbal fluency. And if they can't name 10 or 11 words that begin with the letter F, probably they have impaired verbal fluency. And that is very localizing to the dominant prefrontal lobe. And then the pattern of memory impairment in individuals with Parkinson's disease is more along the lines of what we call retrieval memory deficits. And by that, I mean they can still learn a list of words, but they have difficulty recalling those words. So if you give a patient a list of 5 words to recall, they may be able to learn all 5 of those words. But when you ask them to recall them 5 minutes later, they may recall only 1 or 2. But if you give them clues like category clues or multiple choice clues, the clues will help them recall that word. Now, somebody with early Alzheimer's disease has an amnestic defect early on, so that they have difficulty learning a list of words. So out of 5 words, they may only get 3 at one time. And then when you ask them to repeat the words 5 minutes later, they have difficulty retrieving those words, but clues oftentimes don't help because the deficit, the brain lesion, is in the mesial temporal lobes where we learn new information. Okay, next slide. So another common feature in Parkinson's disease dementia are visual hallucinations. These occur in 45 to 65% of individuals with Parkinson's disease dementia. They are oftentimes complex and very well formed. I have patients all the time that tell me that it rains in their bedroom and they see water on the floor. They oftentimes see small animals or little people under their beds. And sometimes they even see loved ones who have been deceased for years and sometimes can talk to them. It's really important when you're assessing these patients to determine how disturbing the hallucinations are to the patient. Someone with dementia may have a difficult time recognizing that the hallucinations are not real. And so that there may need to be some kind of an intervention because they may be very fearful of the hallucinations, and sometimes they may even act on them. I've had patients call 911 before because of strangers in the room with them. Depression occurs in about 15% of people with Parkinson's disease dementia. And in fact, this can sometimes make their cognitive impairment even worse. So it's worthwhile screening for sadness and anhedonia, and of course, suicidal thoughts. Apathy is also very prominent, and this occurs in about 50% of people with Parkinson's disease dementia. Next slide, please. So there are several different conditions that can be confused early on with Parkinson's disease dementia. One is dementia with Lewy bodies, which clinically and pathologically is very closely associated with Parkinson's disease dementia. And in fact, they have the same underlying pathology. Vascular dementia is just dementia associated with Parkinsonism related to multiple small vessel strokes. Progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration are all known as atypical Parkinsonian syndromes. And they all have features that are not typical for idiopathic Parkinson's disease. They tend not to have tremor, and they tend not to respond well to the medications that really help with the motor features in people with Parkinson's disease. And we'll go over each one of these briefly. Next slide. So dementia with Lewy bodies may account for 25% of all dementias in dementia specialty clinics. We really don't know the population-based prevalence. There's tremendous clinical and pathologic overlap with Parkinson's disease and Alzheimer's disease. And in fact, I have many examples of patients who have very clear syndromes of Parkinson's disease dementia and very clear syndrome of dementia with Lewy bodies and a very clear syndrome of Alzheimer's disease. And when you look at their brain pathology, you cannot distinguish them. So there is a lot of pathological overlap in these conditions. The onset of dementia in these patients is similar to Alzheimer's disease and Parkinson's disease dementia. And of course, the frequency increases with age. Next slide. Of course, to make a diagnosis of dementia with Lewy bodies, you must have dementia, and we define that as acquired and progressive cognitive decline severe enough to interfere with social or occupational functioning. And then they must have at least 2 of 3 other core features. And these core features are fluctuating cognition, recurrent visual hallucinations, and Parkinsonism. Next slide. So I'll just define these core features. They can have marked fluctuations in their level of consciousness and their cognitive abilities that may range from near normal to actually severe confusion. And families will recognize this. You have to ask the question when you evaluate these patients, but you can ask, well, does he have good days or does she have good days and bad days? And they'll say, yes, there are some days that she seems to be herself and other days where she's barely speaking. So these fluctuations can occur over minutes to weeks. They seem to be independent of normal diurnal variation. And they may be so severe that they literally have episodes of reduced levels of arousal where they seem to go blank, and they may even appear to be having a seizure. And obviously, if it's really bad, it may be difficult to distinguish these fluctuating levels of consciousness from delirium. Next slide, please. Recurrent visual hallucinations are similar to those of people with Parkinson's disease dementia. They may be detailed and well-formed. They're frequently of people and animals in the room. And the response may be indifference, fear, or amusement. And then it's important to assess their insight into these hallucinations. Do they recognize they're not real, or are they fearful of them? Are they acting on them? And of course, hallucinations in any case are always worse in individuals with visual impairment. Next slide. And then finally, the Parkinsonism associated with dementia with Lewy bodies. It's found at presentation in these patients in about 25%, and eventually develops in 75% of these patients. They commonly have bradykinesia and rigidity, but it's usually milder than that of seen in idiopathic Parkinson's disease. And the rest tremor is usually absent. Motor features are not necessarily responsive to levodopa like they are in Parkinson's disease. Next slide. So the majority of individuals present with memory disturbance, and they develop Parkinsonism later. And in fact, to distinguish somebody with Parkinson's disease dementia from dementia with Lewy bodies, in Parkinson's disease dementia, they had to have had the motor syndrome, the bradykinesia, rest tremor, and rigidity at least a year before they developed the dementia. With dementia with Lewy bodies, dementia may be the presenting feature, or it usually occurs simultaneously with the extrapyramidal motor syndrome. The dementia is similar to that of dementia related to Parkinson's disease. It's a subcortical dementia with prominent executive function deficits, impaired attention, and again, this retrieval memory deficit or forgetfulness. Next slide. Now, the other 3 conditions I'll just briefly go over. And again, you remember that they're all linked by having atypical features and not responding very well to the Parkinson's disease medications that we usually use, the dopaminergic medications. Multiple system atrophy is uncommon. It includes 3 conditions that we used to distinguish, but now we know they're all linked: olivopontocerebellar atrophy, Shy-Drager, and striatal nigral degeneration. Next slide. The onset age is younger. It's usually around 53. The prevalence is about 4.4 per 100,000. And we usually classify it according to whether or not there's Parkinsonism associated with it or cerebellar problems. Next slide. Did somebody have a question? Did Chad have a question? Or okay. Next slide. You hardly ever see rest tremor in any of these other degenerative syndromes. It's just very rare. And typically these patients have an akinetic rigid syndrome. It may be asymmetric or it may be symmetric. And the other key feature here is they have early postural instability. They may initially respond to levodopa or Sinemet, but they lose response as the disease progresses. Next slide. The presenting features are often autonomic. They commonly have postural dizziness and recurrent syncope. They really can have severe postural hypotension to the point where if they just sit up, they pass out. Urinary incontinence is common, especially in men, and impotence may be the presenting feature in men. And they have abnormal perspiration with very unusual patterns of sweating, and they may have Raynaud phenomenon, cold and dusky hands. Next slide. About 2/3 of these individuals also have rapid eye movement sleep behavior disorder, and they may have sleep disorder breathing such as sleep apnea, central sleep apnea, and then stridorous breathing. And in fact, sometimes this inspiratory stridor is so severe that they require assisted breathing. Next slide. So progressive supranuclear palsy was first described in 1964, so you may recognize the eponym name Steele-Richardson-Olszewski syndrome. It's also very rare, about 6 per 100,000. It's probably underdiagnosed in the United States. Mean age at onset is a little bit younger than Parkinson's disease and dementia with Lewy bodies at about 65 years, and the survival is much shorter, 6 to 10 years, as opposed to 15 to 20 years for Parkinson's disease. Next slide. Falling may be the presenting feature in 2/3, and they oftentimes have difficulty walking and imbalance early on. And in Parkinson's disease, the balance problems really occur later in the illness. So if you see somebody with early postural problems and early walking and imbalance problems, think one of these atypical Parkinsonian syndromes. They oftentimes have double and blurred vision and difficulty with speech and swallowing very early in the course of their condition. Next slide. The Parkinsonism is an akinetic rigid syndrome with very prominent rigidity in the neck. And instead of having the flattened facial expressions that you see with Parkinson's disease, these patients often have a very contracted look of surprise or astonishment with widened palpebral fissures. They hardly ever have tremor. Their neck is often extended rather than flexed, and they have early speech problems, severe dysarthria with a spastic quality, stuttering, and then palilalia, where they may repeat a phrase after a sentence. These patients are also levodopa unresponsive. Next slide. Their dementia is associated with mental slowness, marked apathy, social withdrawal, and fatigue that progresses to a full-blown dementia with prominent executive function deficits. They may have behavioral problems, including disinhibition and anxiety, as well as depression and pseudobulbar palsy. Next slide. Corticobasal degeneration, again, is very uncommon. Men and women are equally affected. Survival, again, is short at about 8 years after diagnosis. Next slide. Again, this is primarily an akinetic, rigid Parkinsonian syndrome. You hardly ever see rest tremor. It's typically asymmetric. They commonly have limb apraxia. And you remember the way we test this is you have the patient do some kind of command, such as, show me how to brush your teeth, show me how to comb your hair, show me how you would flip a coin. And assuming that they have normal language function and normal motor function, if they cannot do that command, then they may have limb apraxia. They have cortical sensory loss, such as astereognosis and agraphesthesia, the inability to recognize a number written in their hand with their eyes closed. They oftentimes have an action tremor that is a jerking quality, and they have prominent dysarthria, and they may have eye movement dysfunction. Next slide. Another peculiar condition they have is alien limb phenomenon, where one hand seems to be independent of what the person intends for it to do. And it can touch things or touch parts of the body without the patient seemingly wanting to do this voluntarily. They may have dystonic postures, and of course they have a dementia that's associated with attention disturbances and frontal executive impairment. Next slide. And then finally, vascular Parkinsonism, and this may be acute in onset or subacute related to strokes. Again, it's usually akinetic and rigid syndrome. Tremor is very rare, and these patients oftentimes have lower body Parkinsonism, where they have lower extremity rigidity, shuffling gait with start hesitation, and early postural instability without a lot of rigidity in the upper extremities or slowness in the upper extremities. Next slide. So how do we distinguish Parkinson's disease dementia and dementia with Lewy bodies from Alzheimer's disease and frontotemporal dementia? So I have the clinical categories, clinical domains on the left part of this table, and then each of the conditions across the table. And as we already said, in dementia with Lewy bodies, level of consciousness fluctuates. Attention may also fluctuate, and it may also be impaired in Parkinson's disease dementia. Language is affected early in Alzheimer's disease, as well as frontotemporal dementia. It may be intact in those with Parkinson's disease dementia, and sometimes language is affected in dementia with Lewy bodies. And then remember, the memory deficits in Parkinson's disease dementia and dementia with Lewy bodies are generally retrieval deficits. In Alzheimer's disease, it's more of an amnestic disorder, and usually early in the course, memory problems are very mild in frontotemporal dementia. Visual spatial function is severely affected and early on in dementia with Lewy bodies. It's usually impaired later in frontotemporal dementia because the part of the brain that controls visual spatial function is the parietal lobes, and the early pathology in FTD is in the frontal lobes and the temporal lobes. And then executive function severely affected very early on in Parkinson's disease dementia and dementia with Lewy bodies. Also in frontotemporal dementia, it's not, if it's affected early on in Alzheimer's disease, it's more mild impairment that kind of goes along with the rest of the examination. Next slide. And then behavioral symptoms, visual hallucinations, very common in Parkinson's disease dementia and dementia with Lewy bodies. Delusions seem to be more common in Alzheimer's disease, and behavioral disturbances are often common in frontotemporal dementia, and often the presenting feature is disinhibition. And in the Parkinsonian syndrome precedes the dementia in Parkinson's disease dementia. It occurs about the same time in dementia with Lewy bodies. And if it occurs in Alzheimer's disease or FTD, it's usually later on in the course of the condition. Rest tremor is commonly present in Parkinson's disease dementia, but really not present in Alzheimer's disease or FTD, and it's rare in dementia with Lewy bodies. Next slide. So how do we treat these conditions? Well, I'll just say the atypical Parkinsonian syndromes that are less common that I reviewed, I already said they don't respond to the Sinemet and the dopaminergic agents for the motor syndrome. And we don't have good data as to how their dementias respond. But generally speaking, I think most experts would say they don't respond very well to the cholinesterase inhibitors or memantine. So you're really faced with treating the behavioral symptoms, and then a lot of speech therapy, occupational therapy, and physical therapy in those patients. For Parkinson's disease dementia, we have some fairly good data from randomized placebo-controlled trials. Rivastigmine is associated with modest but significant improvement in cognition, and donepezil is also associated with improvement in in cognitive function, but in a couple of studies that hasn't been significant, but there was significant improvement in secondary outcomes and in global status. So we use cholinesterase inhibitors based on these trials. For Parkinson's disease at the VA, we start with donepezil, and if they have side effects of that, we move to rivastigmine. Memantine has been associated with marginal efficacy for global clinical impression and improvement of behavioral symptoms. There's really no improvement in ADLs. Next slide. For dementia with Lewy bodies, again, the cholinesterase inhibitors have been reported to improve cognition. They're also associated with less apathy and less anxiety, and they may be helpful for hallucinations and delusions. The hallucinations if you place somebody on a standard neuroleptic, that you will see that these patients get markedly worse. So we avoid standard neuroleptics in these patients. They are very sensitive to them. The first thing that we do in both Parkinson's disease and dementia with Lewy bodies is, if they are on dopaminergic medications, we minimize those as much as possible. And we do it in a certain order. If they're taking an anticholinergic, that would be the first thing to discontinue. And then dopamine agonist, and then finally Sinemet, reduce it to as much as you can. If you are faced with having to treat the hallucinations or delusions with medication, I usually start with quetiapine. I have put patients on Clozaril, but it's difficult to use due to the need to check white blood cell count. So I work closely with my mental health colleagues when I start somebody on clozapine. And then pimavanserin, which has an indication for psychosis in Parkinson's disease dementia. And it's fairly new. I'm only starting to use it. It is available at the VA, but it's not the first medication to try. And then, of course, caution here, atypical antipsychotics associated with increase in all-cause mortality in elderly patients with dementia. So you need to go over this very carefully with the caregiver and with the patient as well, but with the family, so that they understand this. I don't use these medications unless it's in a patient where the hallucinations are really dangerous. And so I'm very cautious about their use. Next slide. I think that, and then the Parkinsonism in dementia with Lewy bodies, it may or may not respond to dopaminergic medications. And most of the time, the Parkinsonism in dementia with Lewy bodies is not the thing that's bothering the most. It is the cognitive syndrome. So it is very rare when I start somebody with dementia with Lewy bodies on dopaminergic medications. Every once in a while I'll do it because of rigidity or slowness of movement. But if you don't get any response, don't keep increasing the dose. You can just discontinue. And I think that's the end of my slides. I'll just open it up to questions and comments.
Hi, Dr. Webb, Relisa Saunders, geriatric nurse practitioner. We've talked in the distant past. I may have missed it, but I didn't hear any discussion about the retropulsion falls. Is that associated with any particular type of the atypicals or all of them?
Yeah, thank you very much for that question. Actually, when I say postural instability, okay, that's exactly what I mean.
Okay.
And just to tell you how I do it, I do what's called the pull test, and that's what you're referring to as retropulsion. I have the patient stand with their feet comfortably apart, and I stand behind them and I say to them, I'm going to pull back on your shoulders a bit to pull you off balance. You try not to let me pull you off balance. If you need to, you can take one step backwards. I will be behind you to catch you if you fall. So you want to be cautious if it's a really big patient. But I give a little tug initially to give them the feeling of what I'm doing. And then I say, okay, now I'm going to pull you a little bit harder. And then I tug enough to pull them off their center of gravity. If they can catch themselves with one step, that's normal postural instability. If they take 2 or 3 steps, that's mild postural instability. If you catch them, that's moderate. And if they tend to lose their balance just when standing, that's severe. So that's a very good question. And you see postural instability or this retropulsion early on in the atypical syndromes, and it usually doesn't occur until later in the course in individuals with Parkinson's disease. Thank you.
Okay. And I have one more question. I haven't had a lot of people with a diagnosis of one of the atypicals, a progressive supranuclear palsy. But in a couple of cases, it seems like, it seems like they're locked in, they can't speak, but they can actually hear what you're saying. Do you know if we have any evidence for that?
Yeah, so I'm not sure that when I use the term locked in, I'm really meaning a specific syndrome related to brainstem strokes that really separate somebody with, generally speaking, good cognitive function from any ability to externally communicate. Patients with, I agree, patients with progressive supranuclear palsy, particularly later on in the course, may appear that way. They likely do have cognitive impairment, so they may not be able to respond partly for that reason, but they do have marked rigidity in their neck and decreased blinking, and may look like they have this locked-in syndrome.
Okay. All right. Thank you. Very helpful.
They also have very early speech problems and mutism, and that even makes it worse.
Yeah. Thank you. Thank you.
Sarah, did you have a question? I thought I saw. I'm not sure how to, let's see. Okay, here we go. Any updates on DBS? Okay. Sarah asked about deep brain stimulation. So deep brain stimulation is indicated for people with Parkinson's disease who have moderate disease where they're still responding to the medications for the motor features, but they're beginning to have motor fluctuations. That is, they are having dyskinesias when there's too much Cinemet, and they're having off periods where they're just very rigid and unable to move when the Cinemet has worn off. So those individuals tend to be good candidates for deep brain stimulation. The contraindications for DBS, one of them is psychosis, and then another one is dementia. So these patients that develop dementia early are not good candidates for deep brain stimulation. And deep brain stimulation for Parkinson's disease, the wires are inserted into either the subthalamic nucleus or the basal ganglia. The wires come out, they're attached to an impulse generator that's embedded into the chest wall, kind of like a pacemaker. And then the neurologist programs that stimulator to deliver a certain amount of stimulation. And it can be very effective for the motor features. It unfortunately doesn't do anything for the non-motor features like depression or dementia or psychosis. Any other questions?
Hi, this is Marcus Pang with Kaiser Home Health. Could you speak to treatments for the frontotemporal dementias?
So actually, yeah, the treatment for frontotemporal dementia, generally speaking, is symptomatic. And by that I mean you treat the behaviors as you would any other type of behavioral condition. There's really no medication that we have that's been proven to really have an effect on the dementia syndrome itself, like the memory problems. And in fact, there's some evidence that cholinesterase inhibitors may make people worse who have frontotemporal dementia. So there are a few studies that are not well controlled that seem to indicate that the SSRIs might be helpful for these patients. And in fact, I often use SSRIs for some of the behavioral problems. Like they commonly have unusual behaviors where they put things in their mouth, or they might other unusual dietary things, like they'll go to the drugstore and buy a case of cough drops and eat all of them. Sometimes behaviors like that seem to respond to the SSRIs. But I usually work closely with my mental health colleagues when I start to use those in these patients.
I just want to open it up maybe to see if Chad Kawakami, our pharmacist, may have any comments on what he has, how he helps primary physicians with this sometimes.
So I guess from a pharmacy perspective and how we help primary care physicians, a lot of times we can help make recommendations on initial drug treatment, but I think a lot of times what we can help out with is the monitoring component and helping to dose titrate. So for example, in the past, I would get like a consult, patients already on, say, I guess I just pick a drug, I guess, say like a cholinesterase inhibitor, and as you know, you have to kind of titrate it up. So my role would be to do the monthly or weekly monitoring with the patient and help the physician titrate the dose up. So that's kind of how pharmacists can help a lot of physicians, is in the monitoring and the management component. But secondarily, I did have a question for Dr. Ross. My question was, in the treatment of PDP, how do you usually start? You probably start with quetiapine first, and then after that, I was just wondering what your experience with pimavanserin is, as far as like the effect, side effects, and yeah, just kind of your own personal experience with that drug.
Yeah. So actually, I work at the VA, and I have to use quetiapine first. So actually, I only have a handful of patients on it. But I can tell you that I've been impressed with the effectiveness of it. There's not a big dosage range, as you know. And so if it doesn't work, I don't keep going up on the dose. I just stop it and try something else. But I have found it to be effective, and I found it to be very well tolerated. I haven't had very many side effects with it at all. And I've talked to my other neurology colleagues in the community that use it a lot more than I do, and they've had their experiences very similar to my limited experience. So I think that it's undergoing trials now for behavioral conditions associated with Alzheimer's disease. So we may seeing it used in that condition as well.
Yeah, definitely. And I think if I can remember, I think some of the data, preliminary data, or at least what they're talking about in the community, is for the Alzheimer's, that it is kind of promising as far as its effect in Alzheimer's as well.
Yeah, I think so. And I'd just like to sort of emphasize what you said earlier, Chad, and that is how helpful the pharmacists are. I am so fortunate at the VA to have pharmacy colleagues who do exactly like what you were saying. And they also help to keep me out of trouble, when I start adding an anticholinergic drug to somebody who's taking a cholinergic drug, or when I start adding multiple drugs that may prolong the QT interval, as some of these antipsychotics commonly do. So I really appreciate the input from the clinical pharmacist.
And then another way that, if you have a pharmacist available to you that can help you out, is a lot of these medications, i.e. pimavanserin, may request prior authorizations. And a lot of times I would help out the physician by filling out the prior authorization, only because sometimes I think some of the pharmacists, we may write these prior authorizations and the criteria. So at least we can kind of like know the kind of the buzzwords or things to say so that the prior authorization goes through like the first time. I know a lot of the physicians on the call with respects to prior authorizations, that thing can go back and forth, probably 50 times until it's kind of like a battle of wills, and finally the physician just gives up because it's too complicated. But sometimes I think pharmacy, we can help out in helping to facilitate that process and using the buzzwords, or even helping to say like, okay, let's try this first, and in the meantime, let's put that prior authorization in for the patient.
Yeah, that's good. Thank you. Yeah.
Great. Any comments from nursing or social work, Sarah or Mary, regarding how you kind of help the caregivers with this?
Can you hear me? This is Mary.
Yes, I can hear you, Mary.
Okay, so I'm a retired public health nurse, but whenever I'd have anyone with any kind of Parkinson's disease, it's just so discouraging and frustrating to see. But I just really, all I could do is the basics, is, you know, good nursing assessment, make sure they have a good medical home. They haven't been seen by a neurologist, assist them to get that done. Make sure they're taking medications as the doctors expected them to. And also the environment, assessing the environment, seeing what we can do to change the environment to make it safer so they can move around more safely. Just basic things like that is what we would do. And also then, you know, letting the doctors know if what's really going on in the home, and if possibly the client's not taking the medications as directed, or they are and they're not doing as well as hoped, letting the doctor know. That's basically what I did as a public health nurse.
Yeah.
With these kind of people.
Yeah, that is that's wonderful, and I really value that kind of input. And once again, I have to say that I'm very lucky to be working where I am. You know, we have home-based primary care, and we have nurses that are able to go out to the homes, and they work with the caregivers. You know, they load the medication boxes, they assess activities of daily living, and then we have occupational therapy and physical therapy. The occupational therapist can go out to the homes and do home safety assessments, and you know, say, you know, remove this rug because somebody can trip over it, because people with Parkinson's disease, as you know, they scoot their feet along the floor. So, you know, a throw rug is gonna cause a fall, and then you want to avoid falls at all costs. They can say where to put grab bars. They can help to open up a shower room to allow entrance for a shower chair or a wheelchair. So yeah, all of those things that you did as a public health nurse, I think they're so important.
Yeah. Do whatever we can to help them maintain their independence at home. Yeah.
Exactly. Yeah.
This is Sarah. I just hi, Dr.
Hey, Sarah.
See you and hear you. And from the social work perspective, what I think has been invaluable in my role, when I was also working at the VA and currently here at the Arcadia family of companies, is the need for caregiver support. And that was highlighted a little earlier from the nurse and yourself. But one way to look at that is I still think, I don't know if they're open, but the Hawaii Parkinson's Association is a great resource. And I just cannot say enough great things about the Hawaii Parkinson's Association. They have newsletters. They usually have a conference, but probably not this year. And they really target their conferences to family caregivers and professionals.
Sarah, thank you. That's you are absolutely correct. Our community is really blessed. Unfortunately, the symposium for this year has been postponed, but it will occur. I'm thinking it's now rescheduled for the fall. But they had a really nice lineup of speakers that have agreed to still come to the conference. So that's a really good resource. And as you said, if you just go online to Hawaii Parkinson Association, they list all the support groups in the state. There's one in Hilo, There's one, there are several on the island here. There's one on the North Shore. There's one on the windward side. There's one here in Honolulu. There are support groups for people with deep brain stimulation and support groups for early onset patients. And then there are several YMCAs.
I was just going to say, yeah.
In the state, especially on Oahu, who have formal exercise programs for people with Parkinson's disease, and they are spectacular. Exercise, I didn't mention this because it's, it's part of Parkinson's disease and not so much dementia because it's a little more difficult, but exercise we know is very helpful for the motor symptoms of Parkinson's disease, and it may actually slow down the condition. So I completely agree. Go to the Hawaii Parkinson Association. It's excellent.
Thank you for that shout out for the enhanced fitness program with the YMCAs.
Yeah.
So we have a couple of questions on the chat. We have here Pat Bemis, right? I am wondering what part of the care of the newly diagnosed patients with Parkinson's disease do you bring up the issue of dementia as a possibility?
So I'll give you my habits, and there are as many ways of doing this as there are providers. But the first time I see a patient, generally speaking, I will educate them about the motor features and the treatments available, and I'll talk to them about learning more about the condition at specific websites. I try to be very specific because there's a lot out there that is just not all that great. But if you go to the Michael J. Fox Foundation website or the National Institutes of Health, there are great resources. There are books that they can read. Generally speaking, that takes up an hour. But then the next time that I see them, I try to go over, and this is a habit that I've tried to get into, is assessing all the non-motor features every time I see a person with Parkinson's disease, and that includes cognitive problems. And I like to have the family member or the caregiver there in the room if possible, because they're the ones that really start to notice these things oftentimes before the patient does. And it's early on, if not the first visit, but the second visit, I begin to discuss these non-motor features all together, and I include dementia and cognitive impairment. And I just sort of give a basic talk about just basically along the lines of what I just gave you. This many people develop dementia over time with Parkinson's disease. It tends to be highly variable. And just because there's this population trend, it doesn't necessarily mean that as an individual, you will get these conditions, but you should be aware of the risk, and you should begin as a family to prepare for some of these things. And by that, I mean, look at the home, see what you can do to make the home safe, begin to talk about driving and some of those other kinds of issues.
Great. I know Pat followed that up saying that, yeah, including the spouse in the visit. And that's exactly.
Yeah. And then I see Joseph asked a question about the cause of Parkinson's disease. That's a short answer. We don't know the cause in most cases. There are very few that are related to specific genetic mutations, but there are very, very few families in the world that are related to a gene mutation. We have a lot of ideas about what might contribute to Parkinson's disease, and that includes pesticides in the environment. There's an association between specific pesticides like organochlorines and rotenone and paraquat with a higher risk of developing Parkinson's disease. But so far, we cannot prove cause and effect. So we're one of the areas that I think are one of the real important areas of research in Parkinson's disease is trying to find, all the factors that contribute to developing Parkinson's disease. And it's probably not one, and it probably is the combination of an environmental factor along with a genetic predisposition. That is, somebody may have a genetic mutation that makes them unable or slow metabolizers of a certain kind of environmental pesticide or toxin. So that when they have that exposure, in the normal case, the normal individual would process that chemical and get rid of it. Whereas in these individuals who are genetically predisposed to slow metabolism, that chemical may stay along longer and contribute toward the cell loss that you see in people with Parkinson's disease. So we say that genetics loads the gun and environment pulls the trigger.
Do you have any other questions, comments? I just want to note, I look in the participants list in the here, and so there are some telephone numbers and we don't know who you guys are. If you could just type your name in the chat box, that would be great. Thank you.
Well, thank you very much.
Well, thank you.
I've enjoyed this very much. This worked out very well. I hope everybody's staying safe and healthy and continue to do so.
Yes. And in fact, we have you on again later on, I think in a couple of months as
Good.
Well. So let me just finish off over here. Yeah. So in order for you to get CME credits, make sure you go to our webpage and complete the online evaluation form. Indicate the type of CE that you'd like. And the link is also found at the bottom of your email invitation. And any comments you have for the planning committee will be used to plan future programs. Tune in next month. Will be Wednesday, May 13th from 12 to 1. And we have not confirmed the topic yet, but we will, and you will get that announcement. Everybody stay safe, stay well.
All right. Thank you. Bye-bye.
Bye-bye.
Bye, everyone.
Thank you.